another segment of the Drexel Seymour Show, where you have to rise up and take a position. We want to encourage you, we want to inspire you, and we want to influence you to make the right decision. Today, I have another segment with Dr. Cory. We interviewed another show with him about COVID-19 and about the vaccine. But I also want to do a show on cancer. Dr. Cory Williams is originally from Jamaica. He got his medical degree from the University of the West Indies, and then he went on to Oxford University, which is one of the top universities in the world, where he got his PhD. And he also did a lot of study on oncology. And I thought this would be an appropriate time for him to talk about cancer here in the world. It's an issue that it's a global issue. Oh, how can I forget? Dr. Cory is married to Sabrina Moyes from Grand Turk, and they have 2 children. I can't forget that. Cancer is impacting almost every family, virtually every family. People are dying, people have died, people are going through treatments. They are, it's men and women, children are being impacted by cancer. We're losing the battle to cancer, but there's some great survivors, of course, who survived, obviously, from cancer. And so we want to have this show today to educate you about cancer, what it is that we can do to alleviate the process. Because sometimes people die, I say we, not me, but some people die because it's late stage. When they found out they had cancer, it was so late. And those who found out early, they probably worried about it so much, they worried themselves to death. And so Dr. Cory, I just want to welcome you again to the Drexel Seymour Show as we talk about cancer.
Thank you for having me.
Thank you. Dr. Cory, and I know that there are many different types of cancers. Roughly how many different types of cancers?
Well, that's a really difficult question to answer because cancer can be described and is described on so many dimensions. So cancer really is an umbrella term.
Okay.
It's an umbrella term for a condition that occurs in nature, in mammals and humans for sure, where cells multiply to an inordinate perspective or standpoint and stage. But that growth, that multiplication of the cells is not normal.
Okay.
It's abnormal when you look at the cell architecture, you look at what's inside of the cells, but also that continued growth, that abnormal growth, over time can have an impact on the rest of the body. And organs nearby, but the rest of the body even further afield by the bloodstream, through spread, or sometimes spread through what we call the lymphatic system. So that's the umbrella understanding. However, there are different categorization and ways of understanding cancer, whether it's by which organ it originated in, so the tumor type, as we tend to call it. And even within tumor type, we speak about solid tumors and liquid tumors. Liquid tumors being those that occur in the bloodstream, leukemias, lymphomas. Whereas
So leukemia is a type of cancer?
leukemia is a type of cancer.
Okay.
And lymphoma is a blood cancer.
Okay.
Right. So blood, liquid, that's kind of one category, and you have different types within that, based on the cell type. You have so many different types of cells. But organ, solid organ, you can have breast, you can have prostate, you can have brain, you can have colon.
So any organ, basically.
Any organ. And even within an organ, you can have different types of cells in that organ where the cancer could originate from.
Wow.
So it's probably hard. And then you could say organ, cell type, but the other aspect is stage. Sometimes, when a cancer starts, and especially for the solid cancers, it's in what's called an epithelial surface, or the surface of the organ. But below that, behind that surface is what is a membrane, a capsule sometimes, right? If the cancerous cells remain in the epithelium,
Mhm.
that's kind of one kind of cancer. We call that, like, generally the cancer in situ or intraepithelial. It's just within that first lining,
Okay.
like the inside of the colon
Okay.
or the inside of the ducts of the breast, right?
Mhm.
If it breaks through that capsule, it's now considered invasive,
Mm.
right, in the organ itself. Or it could spread, as I mentioned, by the bloodstream or by the lymphatic system to a distant
Mhm.
organ. Like here it's spreading from colon to liver or colon to bones, to the skeleton, to the brain. And then that's called metastasis. So it's a metastatic cancer.
Got it.
That means it's a spread,
Mm.
but spread beyond the local geography, right?
Right, beyond that area.
Indeed,
Mm.
because you cannot spread just by invading other organs nearby. It just continues to, let's say, eat away, or it could spread going far away via the blood. One cell breaks off, jumps in the bloodstream, and goes far. So with all of those different dimensions, you can have so many different types of cancer.
I understand.
But the basic pathology or pathologic mechanism behind it is around these aberrant cells growing uncontrolled in an uncontrolled fashion.
Mhm.
But the growth is also showing manifestations that are different from normal cells.
So, what causes this growth? I mean, I guess there's different reasons, but
Right.
what is the fundamental, the main reason why these things are growing?
I like to think about the cause of cancer at least through two broad starting points.
Okay.
And then you can, within each of those starting points, you can chip away and get more details. So there is what we call nature versus nurture,
Okay.
right? So what is your genetic and biological makeup?
Mhm.
In large form, what you inherit from your parents from birth and what goes with you for life. So that's one. And two is what is you're exposed to in the environment.
Okay.
So there's nature and nurture. It's kind of what's in your body versus the environment.
So, are you saying that cancer can be hereditary?
Oh yes.
Really?
Oh yes. Many cancers are hereditary. Many cancers are hereditary. And there itself, there's a fascination, at least in my understanding, around trying to unlock what that. Some of it is known.
Mhm.
Some of the hereditary basis of cancer. You know the particular gene. You know what to expect. Others still unknown.
So
It's just
okay.
you just have perhaps the signal because you realize this particular cancer is going through this family. There's an aunt who has it. There's a daughter, but maybe they don't know the genetic background. But and we tend to call it hereditary or familial.
The reason I ask you that, right?
Sure.
About several years ago, maybe about 3 or 4 years ago,
Mm-hmm.
there was this doctor who came to our church. He was invited by our pastor,
Mm-hmm.
and church was full of people. It was well attended, and he said that there's no such thing as hereditary diseases. He said what happens is that it so happens you're in the same family and you're eating the same food, and that is why you're having similar diseases. He said nothing is hereditary. He said it's the food that you eat. For example, my wife and I, we have 5 children, all of us eat the same food.
Mm-hmm.
And because we eat that same food, that food may not be healthy, and so all of us end up becoming sick from the same type of disease from that food. He said we cannot pass something from one person to the next. That's what's his claim. So I'm interested here. It's interesting that you talk about the nature versus the nurture.
Indeed.
And that's why I thought I brought that up as
Indeed.
well, based on what he said.
Indeed.
You know.
So I would differ from his
Of
position.
course, yeah.
And but I do recognize, and that's why I mentioned nature versus nurture, both oftentimes play a role.
Yeah.
Oftentimes they both play a role. In some cancers, maybe one plays more of a role or a major role compared to the other. Let me unpack a little bit, going down the two starting points
Yeah.
to give a little bit more of a flavor of it.
Sure.
On the genetic, familial, background, hereditary side, the genes that cause cancer or could lead to cancer form into two broad categories again.
Mm-hmm.
The first are what we call oncogenes. Right? So these are genes that code for proteins that when there is a mutation in that gene and it leads to then an aberrant protein from that. You remember in our previous show and discussion, we spoke about genes and going from DNA to RNA to proteins.
Yes.
So the genes that code for a particular protein, if there is a mutation in that gene, can lead to a whole host of an aberrant protein types, right? The protein could be shortened, the protein could be malformed in terms of how it's structured. But for oncogenes generally, when they are when the proteins from that malformed gene or from that mutated gene, those malformed proteins, they tend to drive proliferation. They tend to drive growth. Because remember, going back in the homeostasis of the cell, there are some proteins and some factors that are pushing for growth and multiplication and proliferation, and there are others that are trying to keep a check. The oncogenes, when they are mutated and the proteins push proliferation more and more and more. That's kind of one subtype of genes in cancer. The other subtype is called tumor suppressor genes. So their function, generally speaking, in the normal homeostasis of the cell, is to keep things in check, to keep things solid and contained. For example, many of our cells, as part of living, multiply. Like your cells in the lining of your colon, over time, some of them slough off and they drop off and they replenish, right? In the liver, replenish, right? Your skin cells, they replenish. That replenishment is driven by a cell replication process, right? Where the cell essentially replicates its internal DNA and then it splits. So one cell, one DNA strand, I'm just being simple for effect, multiplied into two, and then that kind of mother cell, the two strands, then splits into two daughter cells with the same genetic background as the first one, because this is in one organism. In that process, to replicate, you need to ensure that replication goes perfect. So there's a reading, there are proteins that read the DNA, the code, and checks ACGT, for example, checks from the parent to the daughter that the right replication occurs. So it's like creating a blueprint from the mother to the daughter cell. If anything goes wrong, and there are some proteins that do the checking, if those can't check as they should, then an inherent mutation could pass through and be missed. Those, again, broad brushstroke, one of those proteins that perform that checking mechanism actually is checking for potential mutation that could give rise to cancer. So, and that is then called a tumor suppressor protein. But if that tumor suppressor protein is somehow compromised, then it can't check, and the mutation could pass through. So oftentimes in family cancer syndromes, it's around a tumor suppressor gene, right? And whether from the mother or from the father, it gets passed down. So you may only have, because going back to genetics a little bit, each of us as an organism, as a human, broadly speaking, as a baby, as an embryo, we inherit one, because we have two, for each gene we have two copies. One inherited from your father, one from your mother.
Yes.
If one of them is already mutated in this tumor suppressor gene, at least you have the other one to get by. But if through replication processes, that second one, the good one, gets compromised because for some reason it doesn't get checked, then you now have the potential starting point for a cancer in that one cell. Because all cancer starts in one cell. So that gives you the tumor suppressor side, keeping control versus the oncogene side, driving for growth, driving to do something different. So broadly speaking, that's on the genetic background.
Right. Which is the nature.
Exactly.
Part.
Exactly. On the nurture side, environment, very interesting. So we get exposed to different things in life, whether it's, food you eat, your diet more broadly, your lifestyle. There are many examples. I could select sunlight. Sunlight is radiation. And when radiation hits your skin, that radiation can actually lead to genetic changes in the cells in your skin. Generally speaking, but not foolproof, not 100%, but generally speaking, folks like us, because of our melanin background, it's somewhat protected. But we can still get skin cancer, for sure, melanomas, right? If you have that
It's because we used to be, and then talk about because of our skin, but it's because we also live in an area where we're used to the sun or that.
But that actually, going back to human evolution and biology, actually is protective. So, our forefathers going back hundreds of years, being exposed to sunlight in the tropical, in the torrid zone, actually led to humans in that belt developing more melanin to protect against the sun.
Okay.
But that's a whole other topic. Human evolution and biology. But to your point, to your question, that protection is there. But let's say you don't have a protection, maybe fairer tones. And again, even for those of us who have high melanin content, we can get melanomas. Just using melanoma as an example. Sunlight comes in. Let's say you had one inherited copy that was already mutated. Sunlight then hits the other one, other copy of that gene in that cell. So now you have two bad copies. So that tumor suppressor is now fully non-functional.
Got it.
And that one cell can then replicate and pass that two bad copies down, and it keeps on going. So but remember, in that example, tumor suppressor gene in the family, one was inherited. But it shows you the link between nurture, the environment on that side, sunlight in that example, and nature, because we inherited one copy. That was bad. That's kind of one example.
That is very interesting.
But so that's the dynamic.
I understand.
For some cancers, it tends to be less an issue of the nurture side, and it's just you have a bad oncogene and it pushes through. But broadly speaking, those two families of genes and nature and nurture interplay.
But doesn't it seem strange though that many years ago maybe they were, we just didn't know. But many years ago we never used to hear about cancer, people dying from cancer. And now all of a sudden, cancer. Is it because people did die and we didn't know?
You're right.
Because this is so strange. It's like almost everybody, or at least one family member, has been impacted by cancer.
You're right. It's fascinating, and you definitely have hit the nail on one of the key factors why we're seeing so many more cancers now. And definitely awareness is much stronger, it seems, compared to before. So one is screening and awareness.
Okay.
So we're definitely more aware and are looking for more and are more vigilant in today's world compared to days gone by. When you think about different screening programs, so there's for breast cancer and doing mammograms, for prostate, and it's PSA and other parameters. When you think about colon cancer and doing colonoscopies, screening actually brings to the surface what would have probably gone unnoticed in the past.
Okay.
So that's one, better screening. Two, better detection. We now have way more high-powered technology platforms to actually detect cancer at an earlier stage than we did in the past. So that's a second. A third, and oftentimes maybe unnoticed factor is, as a race, we're living longer. So whereas in the past,
You think so?
we are.
Yeah.
To be honest, COVID-19 probably will put a dent on that when you step back and look at human evolution over time. But putting that aside, in today's world, compared to 100, 200, 300, 400 years ago, I would say we're living at least a decade as an average across the population.
Got it.
So what does that mean? In addition to what I said before, better screening, better detection, better awareness. The longer you live, so one risk factor for cancer is age, no matter how you think about it. Maybe some of the reasons that could provide some substance to that is, the longer you live, the greater the likelihood that you could have cells as they replicate and cycle, that an aberrant gene comes in that goes unchecked. So more time, law of averages,
Makes sense.
and we're living longer.
Makes sense.
So all those factors kind of play to your point that we're seeing and are aware of, and it's definitely more in our consciousness compared to decades and centuries ago.
So you talk about the screening, you talk about detection. So that means then that we need to get screened, get tested, basically. And how soon should we do? How often should we do that?
Good question. It varies depending on the type of cancer. For example, the solid organs and liquid, as you spoke about, and even among the solid. So, for example, and I may be off, but from what I recall, from a colon cancer standpoint, and let's say prostate in men and breast in women, usually in the 40 to 50 period of age, screening programs suggest that you should start getting checked. And maybe first 5 years, and then maybe after a certain point, it gets more frequent. So that's kind of one. I mean, 45, 50 is usually the starting point, but that can change depending on your family history.
Oh, that's true.
Right. So, and that's why I gave you a range, because you can start. It's multifactorial, and the physician will definitely look at your case because each patient is different, and determine what's best for you. So, for example, if you have relatives, let's say it's a lady and she has a relative who had breast cancer, and depending on one, how many of them had it, at what age they had it, it will then trigger should that patient actually start screening earlier than the average population.
Makes sense. Makes sense.
Because there's a likely predisposition to cancer, to breast cancer in that case. If they have the gene of interest based on sequencing that gene perhaps from the relative that had it, even more information to target the surveillance and the screening program to ensure that you get it assessed and detected early if possible, and there can even be preventive measures that are taken. The other aspect, going back to hereditary and familial, is how close is that relative to you. So you have what's called more of a index relative or primary relation, mother, daughter, sister, in the case of breast cancer for women, versus maybe a cousin or a grandmother or a second order relative. The closer to you, the higher the index of concern and suspicion, which should then inform screening and surveillance programs for you as a patient.
Wow, yeah, makes a lot of sense. So for Amanda watching the show, I mean, with the prostate cancer, it was just, I know you talk about the age, the average range, but what sort of symptoms do you have? Say you didn't do, I mean, if you have prostate cancer, what are some of the symptoms?
The sad thing with prostate, and to a large degree for breast as well, you don't really want, because by the time you have symptoms, it's further than you would want it to be.
So you're probably in the late stage, maybe?
Oftentimes, yes. Oftentimes, yes. So when you think about the prostate, for example, it's a deep-seated organ. It's deep in the pelvis. It's close to the bladder. The symptoms that you tend to have from prostate, changes in your urination, for example, because the prostate that sits around the urethra, which passes urine from the bladder into the lower urogenital system, wraps around that urethra, right? So you can imagine if the cancer gets in, and going back to our previous discussion, expands into the local tissue and starts to compress on that urethra, past where the fluid, where the urine passes through, you could have a stoppage of urine, for instance. Sometimes you may have frequent urine, but changes in urinary biology for you as for you yourself to be could be one. But again, that usually means that that's gone for a while. But to your personal symptoms, that could be one. Sometimes pain. Usually in today's world, going back to screening and or surveillance, a PSA, and PSA stands for prostate specific antigen, is a protein that is associated with the prostate, and when high above normal levels can indicate cancer. It can also be high in non-cancerous situations, and that's the reason that it's helpful once you should be on a surveillance program with your physician. Two, if it's seeing you do a broad battery of tests to determine is this cancer or not. But it's very sensitive to say if there is cancer. When it's raised, you should have a high index of suspicion. And so symptoms are one thing, but I would say in today's world, let's not wait on symptoms. Let's do active surveillance. And PSA is usually the starting point. But around that, you could do rectal examinations regularly with your physician. Because again, if there is any hardness or nodule that's felt in the prostate on the rectal examination, it could mean cancer.
That's a good point. So it's really important then for us to, men and women,
Indeed.
to get screened,
Exactly.
get tested, do some screening.
Exactly.
On what? Twice a year?
So again, early, I believe for prostate and colon, and likely breast as well. Once you start, let's say in the 45 to 50 range, it starts as every 5 years.
Oh yes, you did say that, every 5 years.
And then as you get older, maybe I think at about 60 or 65, you'll start getting more frequent. And that's kind of for the average in the population. Again, if you have any family or hereditary situation or history in your family, in your case, you would actually start earlier and perhaps more frequently, customized to your situation. But broad brush, the kind of average would be 45 to 50, starting 35 years.
Got it. Some males, they don't want to go through getting tested for prostate cancer. And as I said earlier, that especially find out because, if you don't, and when you do get tested, it may be too late.
That's so true.
Yeah.
And particularly important in the case of prostate cancer. So going back to our previous discussion, the prostate is a gland, so it secretes fluids and other material into the urethra that support, for example, semination and the support of spermatozoa in the fertilization process. The capsule is fairly well contained, and oftentimes, when caught early, the cancer cells have not reached the capsule, they haven't gone further. So there's a very high likelihood and probability of cure, essentially.
Okay.
That's why it's important to catch it
early.
And while I understand that sentiment, I would encourage all males, all of us to work through that.
Yeah.
PSA is an additive parameter that can be used by your physician to survey and to do regular checks. But we need to work through that because, to your point, the benefits that could be accrued from catching it early make a lot of sense.
It's best to find out.
Indeed. And today's world and the types of therapeutic approach that you can go through, surgery, but there are more specialized types of surgery now that actually allow you to remove the cancer and preserve the tissue around in a more precise way than in the past. So, one, high chance of cure. Two, very high chance of returning to a normal life.
Yeah, absolutely. And so with the cancer, especially with breast cancer, I guess, you go through chemotherapy. Tell us about that process.
Indeed. So cancer therapy has actually gone through quite a transformation, I would say, over the last 10 to 20 years compared to where it started out in terms of cancer chemotherapy, maybe in the 1950s or thereabout. The approaches then, just based on what was known and the research outputs, were to essentially provide noxious agents to kill the rapidly proliferating cancer cells. And to cancer chemotherapy, that's the bastion of where it started out. It's like bringing ammunition. But the ammunition, looking back from where we are now, was blunt as an instrument. It's like coming in and you want to hit down a particular wall from a construction standpoint, but you hit down the entire house just to get the wall. So what ended up happening is you had a lot of side effects because the noxious agents actually hurt normal cells, bystander cells nearby. And that's why with chemotherapy, nearby in the body overall, that's why, because it hits proliferating cells, right? Cells that are naturally replicating. That's how cancer chemotherapy started.
Oh, okay.
So when you think about other parts of your body that are replicating just through the normal course of their physiology, hair cells, cells that line the gastrointestinal system, the gut, cells in your respiratory tract, they'll get affected as well. That's why you see people losing their hair. You have people having diarrhea and having very bad symptomatology and side effects in their gastrointestinal and even in their breathing system and elsewhere, skin, liver as well, because it was blunt as an approach. But that's what was available, that was what was known. Over time, the benefit of cancer therapies generally have been accrued through more targeted and more precise ways of addressing the cancer itself and really focusing on the cancer cells themselves and not so much the other normal.
All right. So that's a lot of progression.
A lot of progression. But chemotherapy, to your point, that's the kind of thing. It's like, let's hit these cells because they're replicating with very noxious agents that stop replication and hurt the cells when they're replicating and kill them. But there are side effects. Over time, going back to a previous discussion, understanding the oncogenes and the tumor suppressor genes and the mechanisms and the pathways, you have now more options from targeting the blood vessels that support the cancer cells. Rather than killing the cells themselves, you shrink. Because if they don't have blood and they don't have oxygen, the cancer can't live. Right? That's kind of one approach. There are other approaches where it's kind of a lock and key. You understand the gene mutation, and that gene mutation leads to a particular protein that's structured a certain way. But it's that gene and that protein where it's occurring could actually be a receptor on a cell or a protein in a pathway. You actually create your molecule, your therapeutic, your drug, to actually block that special formation. So the signal that would have been passed through that mutated, malformed protein is stopped. So that's more precise, what we call targeted therapies, precision medicine.
So that's the case, then. Why are people who thought they were in remission end up getting cancer if they came back with it?
Good question. Multiple factors. Multiple factors to be considered. So cancers, sadly to say, are very smart. They often behave as an organism of their own with the intent to survive. And when one therapeutic armamentarium is brought to them, they try to their best to sometimes mutate further to actually find a different way to survive that circumvents and doesn't need that which was blocked before. So they constantly are mutating to find new ways.
Very smart.
They're very smart. Number two, cancer could have multiple, what we call subclones, like subfamilies within. Because remember, it started from one cell.
Yeah.
But as one cell replicates and splits and splits and splits, another mutation could then arise in those daughter cells. And again, going back to the way of thinking about or paradigm of it's like an organism trying to survive, and maybe in a way similar to our discussion around viruses.
Yeah.
The cancer cells, when the environment triggers that either make them survive better, or they're going to try and react to something that's trying to hurt them, they mutate to get around that. So the daughter cells and subclones, subfamilies may be different from the parent in one cancer. So to your point, when you have the treatment, and the treatment is probably, whether it's oftentimes chemo and targeting, it probably kills one subfamily, but there's another subfamily that wasn't affected or actually is born out of that initial treatment. So that is a general way of understanding why you have remission or recurrence sometimes.
So there are different stages in cancer. Stage what? Stage 0, 1, 2, 3, 4, 5.
Broadly speaking, yes.
Yeah.
Broadly, some cancers use different classification mechanisms, and sometimes maybe they'll go all the way, but generally speaking, 0, 3, 4, or 5.
Okay. So is it possible that even if you're at stage 5, you could still be okay? Or if you're at stage 5, that's it?
Again, hard to answer because depends on the tumor type you're talking about. For some tumor types, the severity and let's say mortality and prognosis of a stage 4 is different just because of where it is, where it has spread to. Because stage 4 is what spread. Has it spread to the brain and to the spinal cord or to the bone? And it can perhaps through palliative care and other supportive therapeutics you can live. But broadly speaking, if you are kind of end stage,
which is stage 5,
yeah, stage 4 or 5, it tends to be a dire situation. Terminal. Maybe the period could vary based on the person and the organs and where it's metastasized or spread to. But broadly speaking, that's the case.
But you've seen cases though whereby people were at stage 5 and it was able to recover. You've seen that?
I've seen stage 4.
Stage 4.
I've seen stage 4.
Okay.
And again, depending on the cancer type.
Yes.
And the therapy that they were.
And that's why it's important to get tested early.
Indeed.
So we talk about the screening, we talk about the testing. What other things can we do to help or prevent us from getting cancer? I mean, I know maybe it may be tough because we talk about nature, we talk about the nurture. In some cases, you don't get it from your family.
Right.
But given everything else, what are some things we can do?
It's a good question. Let's take nature first. So if you know that there's clearly a family history of cancer, and even more so if you know what type of gene may be abnormal, because you did perhaps some testing of family members before and the gene of concern was identified, and or through screening events you know and identify that gene. Based on the tumor type, you can take action.
Okay.
For example, and just give an example just to frame the discussion. Some women who have a family history of what's called the BRCA1 or 2 genes. So BRCA, BRCA, just stands for breast cancer.
Okay, I figured that.
It's a type of familial breast cancer. Some women opt for prophylactic mastectomies.
Okay, so they just remove their breasts.
Indeed, because if there's no cell that can become mutated because of that, that can become mutated or lead to cancer because of that inherited mutated gene, then you reduce almost to zero, essentially to zero, the risk, right?
Okay.
And of course you can have prostheses procedures and so on.
I think I interviewed someone before. I think she had said she was diagnosed with breast cancer in one breast.
Right.
So what she ended up doing, removing both breasts.
Indeed. Indeed. Some women do that as well.
Mhm.
So you can do it prophylactic, which is even before you
were diagnosed.
Right. Exactly.
Because of your history, your
Because of
family.
your family history.
You don't
Exactly.
want, the chances are you may get it.
Indeed.
And so, okay.
Or to the case you just mentioned, after having developed one cancer in one breast, whether or not it's having a strong familial linkage,
Mhm.
to prevent the risk of recurrence. Because sometimes even when you treat one or two cells as
Yeah.
and those one or two cells could go to the other breast, seed, and then start a new cancer, you can remove that risk.
Okay.
So that's kind of one example.
Yeah.
In the broad, what else can you do on the genetic side? On the nurture side or the environmental side, there are probably a lot of other examples of what you could do. There's a lot of literature, a lot of recommendations around diet, lifestyle, broadly. And then for particular types of cancer, there are additive measures. So going back to melanoma that we spoke about before, wearing sunscreen, trying not to be exposed directly to sunlight for too long periods, right? Again, fairer complexion folks probably have to lean into that more than others, but I wouldn't say it's night or day or yes and no. For all of us, we need to be mindful, use sunscreen, don't get exposed for too long to ultraviolet radiation from a skin cancer standpoint. For others, for diet, for example, it's fairly well researched and understood that the type of diet, so eating food with a lot of what's called from grilling or barbecuing, so the
that's good? That's
not
healthy?
good, not good.
Oh.
So
grilling, food that's grilled and food that's barbecued.
right. So
Okay.
outdoor, where there are extremes of this. So first of all, highly processed foods. So when you think about a lot of what's in canned and cured meats and so on, a lot of those tend to have, because of the curing process, molecules that can be carcinogenic, right? Similarly, it's been shown with outdoor barbecue and grilling that can lead to molecules, again, or compounds that could trigger. So a lot of this research...
That's interesting. Because a lot of people believe that grilled food is healthy.
Outdoor grilling, though. I'm talking outdoor grilling where you have a lot more of those noxious carbon derivatives and carbon products as a result of grilling something indoor.
Okay.
But broadly speaking,
no, I hear what you're saying. That's
those are
good to know.